All right, so we'll finish up this section, move on to the next one. Again, any questions from last time that we met? It's only been 2 days, so hopefully you haven't lost everything, right? Hopefully. Yes, ma'am.
So are there any drugs that have actually a higher effective dose than its lethal?
Interesting. So the effective dose is higher than the lethal dose might be. No, because your patient would be dead at that point, right? However, there are some examples where there's actually almost complete overlap. So imagine a drug, a paralytic, right? So if I needed to paralyze someone for either intubating them or for surgery, if I'm not breathing for them and I paralyze them, that diaphragm is going to go out, and guess what? They stop breathing, and then you die, right? So in that case, the effective dose is to the point where I want them to stop breathing because either I'm doing it for them with a ventilator, or I just need them to stop moving at all for surgery. And so in those cases, that's the thing where the patient would die, but we are providing the life support in order for them to not do so. So I guess that would be one example. I'm trying to think of any other good ones. It's kind of my go-to though, is the paralytics. Very dangerous drugs. Be very careful anytime you're using a paralytic. Anyway, any other questions? I did find out, so if you remember, there's a question on the sticky board last time about redheads and needing altered doses of analgesia. I looked it up. There is something to it, although clinically, we don't know how relevant it is. So what I found out is that the mutation that's associated with red hair color actually has something to do with pain tolerance, and they found that generally they need more inhalational anesthetics for surgery, but less opioids for pain control. There was one study where they actually were looking at surgical patients who had red hair, and they did a nice case control study where I think they had like 300 some odd patients with red hair, and they found that clinically, though, there's no difference in outcomes in terms of how well they did in surgery, and recovery times and everything was pretty similar. So interesting, I learned something new thanks to whoever asked that question. So there you go. Does not count if you do not have natural red hair, though. As I see a few, I don't know who it was, but anywho. So it's kind of like a superpower almost. So better pain tolerance. Anyway, any other questions at all? All right, let's keep going. So we're looking at kind of reasons why people have kind of differences in responses to medications, right? So we went through a few of those. One could be genetic factors, right? So people's receptors could just be different in terms of how they respond to medications in terms of affinity or how they're actually, how long they're binding for it. And so you can find, like in this example here's one that tends to be 10 times more prevalent in, say, African-American patients and Caucasians. However, a lot of these we don't necessarily know the clinical relevance of and if it actually has any big impact, but just know there could be differences there that we may not have accounted for yet in terms of why someone responds better than another person to a medication, right? You'll find that when you're practicing, there's like always one person who just kind of reacts really weird to a medication. Sometimes it's a genetic factor that you're running into. Next, you could have sort of distal downstream sort of effects that could be occurring to limit the effectiveness of some of your medications here. So imagine, I mentioned that the body likes to maintain homeostasis. So if I try to alter one thing, say for instance, lower the blood pressure, what is the body going to try to do to compensate for that? Raise the blood pressure back up. And so there's a lot of different ways we can do that. And so what are some of the systems that we have that regulates blood pressure? Kidney, we have baroreceptors, we have covered the renin-angiotensin system yet? That's a big one, right? So for instance, if I give a beta blocker to help lower blood pressure for a patient, you may find that the kidneys don't like that drop in pressure. They're like, hey, we need more blood flow here. Let's go ahead and try to alter this. And so they'll start to increase release of renin, which gets eventually turned into angiotensin 2, which raises blood pressure, right? So you can find that you may start a patient on a medication is working great, and then over time you may find it has diminished effects. A lot of times this is compensatory mechanisms that are trying to kind of dampen that effect there. And so how do you think we would interact? How do you think we would kind of overcome that? You could increase the dose. That's one way. What else? Yeah, I could actually add on another medication that affects that renin-angiotensin system. So when you see patients who are on multiple antihypertensives, they're usually on different mechanisms such that they're working synergistically together to try to impede some of these sort of homeostatic sort of mechanisms, if that makes any sense. Anyway, so you're going to find there's lots of cases where this happens, and we'll cover them individually when we get into the specific classes next semester. So anyway, getting into clinical selectivity, so looking at the beneficial versus toxic effect of medications, because again, are there any drugs that have zero side effects? No, they probably wouldn't be very good drugs if they had no side effects, because you're going to find that a lot of the clinical effects that you see tend to be, the toxic effects are extensions of those in some cases. Sometimes they're completely separate. But you're going to find that drugs tend to have some selectivity towards a particular type of receptor. You may find that drugs are extremely specific and only affect one individual type of receptor. Sometimes they are less specific and they will affect lots of different types of receptors. When they affect a lot of different types, what do you think that does to the, say, number of side effects that it can cause? Probably increases quite a bit, right? So as an example here, looking at the difference between chemotherapeutic drugs, which we would use to treat cancer, versus using antibiotics, you're going to find that typically antibiotics are going to be a lot less toxic to people because we are trying to target those bacterial cell targets, right? Our cell walls are different than bacteria, our DNA is different to some degrees, and so by using medications that are very specific for those targets, they limit the toxicity that we get. Now, does that mean there's no toxicity with antibiotics? No, there's still plenty of toxicity because it's not 100% completely selective. There's other issues that come into it as well. However, looking at chemotherapeutics, you can find that a lot of the old school sort of chemotherapy drugs, they can't tell the difference between a cancerous cell and a healthy cell, and they will kill off both to the same extent in a lot of cases there, which is why you find that we have to kind of give patients chemotherapy. We have to kind of like knock down their immune system, knock down their GI tract, and then give them time to recover. Hopefully the healthy cells will outcompete the cancer cells, and then you give them another cycle. And you do these kind of cycles of chemotherapy. We'll talk more about that later, but that's a general idea of looking at that selectivity and seeing how the toxic effects can change pretty drastically in those cases there. Typically, though, higher selectivity means you're going to be getting the efficacy that you're looking for and hopefully less toxicity overall. And a lot of this can be dose dependent too. So for instance, if you're looking at, say, a drug that is a beta blocker, right? We talk about beta blockers. What type of beta receptors do we have? Beta 1 and beta 2, right? There's beta 3 too, but we don't really care about that in terms of drugs in a lot of cases, but beta 1 and 2 for our purposes here. So we have drugs that can be very specific just for the beta 1 receptors. And we'll use those in certain cases versus non-selective beta blockers, as we'll see when we talk about hypertension and things like that. But what you find is it typically is going to be dose dependent, which means if I drive the dose up high enough, if there's enough drug around, things can lose their selectivity to where they'll actually interact with both types of receptors. So I can have a drug that says very specifically is beta 1 selective, but it's going to lose that if the dose drives up, and I can actually affect beta 1 and 2. So just know that selectivity is always relative, and it's always going to be in terms of the dose. If I keep driving it up, selectivity is generally lost. Okay. So, and again, we can measure this by actually comparing the ED50s for different medications there to kind of see what sort of selectivity we're getting out of that. And typically when we're using, we're actually like developing drugs themselves, we usually try to separate these out in terms of like what are the therapeutic effects we're looking for, and then also sort of the toxic and side effects. So we're talking about that already in terms of therapeutic index and kind of comparing those curves together. Remember, when looking at a therapeutic index, is a large number or a small number generally better? Large, right? You want a lot of, as little overlap as possible between your therapeutic and your toxic effects, right? So that ratio, the higher that is, the safer the drug is typically. So let's look at the fact that in some cases, the beneficial and toxic effects are mediated through the exact same receptors, right? So this is where, again, talking about the paralytic, right? We like the paralytic because it will keep your muscles from contracting, but also it'll stop you from breathing. Typically a bad thing, right? Unless we're doing it for you. That is through the same exact mechanism because it's all paralyzing the muscle, right? For example, with Coumadin, we talked about warfarin being a blood thinner. What's the main toxicity you're going to find with that? Bleeding, right? So again, it's all mediated through the same effect there, and that's why we have to monitor it so closely to make sure you're getting enough to not cause a clot, but you're not getting so much that you're also going to be bleeding out, right? How about insulin, right? Insulin's normally used to do what? Lower your blood sugar, right? What happens if I give you too much insulin? You get hypoglycemia, right? So again, it's all along that same mechanism there. And again, we have to weigh the risk versus the benefits there to see like, okay, well, if I know this patient's really at risk for developing a clot, but also they may be at risk for bleeding, you have to kind of compare that. So as an example, like you'll have older patients who, have AFib or they have a history of PE or something like that to where they need to be on a blood thinner, right? However, old people, when they get older, they maybe, they can't get around as well. What are they at risk for? Risk for falls, right? So what do you think happens to an anticoagulated patient who falls and hits their head in the shower? They can get a big subdural hematoma. They can have some very significant deleterious side effects there. So you have to kind of weigh the risk versus the benefits. Well, I don't want that person to clot, but I know they're a big risk if they do fall for having a bleed, right? So again, there's a lot of things you have to consider when using the medications. And again, it's all through that same effect, right? The same receptors, the same mechanism there. Now, sometimes you can find there will be different tissues or different receptor targets that the drugs will have their toxic versus their beneficial effect. So let's look at an example of using drugs in one tissue versus another, right? So as an example, looking at glucocorticoids. When I say that, what does that mean to you, you think? What do you think glucocorticoids do for us? Like steroids, but they're anti-inflammatory, right? So you use glucocorticoids quite frequently for a lot of different conditions. So if you ever heard of like prednisone or methylprednisolone, Medrol, dose packs, things like that, right? They're glucocorticoids. Well, if I have something like an asthma or COPD exacerbation, primarily what organ would I like those drugs to work in? The lungs, right? However, if I give you a tablet, is there any way to tell that drug, hey, just work in the lungs? No, it's going to go systemic and it's going to see all kinds of side effects. So I can see that the blood sugar is going to raise up. You might hold on to more fluids. You might see some weight gain associated with that. The lungs will be better, right? They'll decrease that inflammation, but you're going to find that you can have toxic effects in different tissues that you're not really intending to even have an interaction with. What's one way I can get around that, though? I could have an inhaled formulation, right? So that way I can give an inhaled steroid and only get effects in the lung versus trying to get more systemic. So in some cases we can get around that. Other cases we may not be able to. So as an example, when someone comes in with a severe asthma exacerbation, it takes too long to give them an inhaled corticosteroid for it to be effective. I'm just going to go ahead and give them systemic steroids because I know that's going to be more effective. It's going to really knock that inflammation down, and then they can eventually transition over. So sometimes we have to kind of take the good with the bad in those situations, depending on what the clinical case is. Now, looking here, if you can see the toxicities in other areas, they're bound to the same receptors, right? So the corticosteroids work at the same sites. It's just in different tissues that we're dealing with. So as I mentioned, you can see things like diabetes getting worse because your blood sugar is going to be raised. You can see things like fluid retention because it has some effects on how the kidneys are going to handle water, right? And so in these cases here, the goal is to try to use the lowest dose possible. If you can avoid using the drug in the first place, that's always beneficial. And then, as I mentioned, use more direct routes, or perhaps use drugs that have an alternative mechanism of action to try to maybe get around these negative effects in the first place, right? So looking at this, here's another example here where you'll find that drugs may bind to lots of different types of receptors, and if we can try to separate those out, that's always going to be beneficial to limit some of these toxic effects. So as an example here, like epinephrine, right? Epinephrine binds to lots of different types of receptors, mainly which ones? Alpha. Alpha typically does what for you? Constricts and raises blood pressure is a big one. And then what other receptors? Beta 1, beta 2, right? So again, they can act on different receptors. You'll find different effects. Now, if we can try to peel those out, maybe only have a drug that's specific for one of those, that may help to limit some of those side effects. So as an example, if I give someone epinephrine for low blood pressure, I can get that blood pressure up, but also what does it do to the heart rate? It increases it. Well, what if I had a drug that just affects the alpha receptors alone? I can hopefully raise the blood pressure and then not actually do anything with the heart rate. So again, sometimes being able to select out for that can be beneficial depending on the situation, right? And then there's in some cases where we can actually make drugs that are very specific to one type of an enzyme, one version of an enzyme that helps with some of those toxicities. So as an example, if we'll talk about COX-2 inhibitors. We'll talk about cyclooxygenase being a very important target for inflammation, and that's why we use NSAIDs for that. But if you can specify and just affect COX-2, you can actually limit some of the gastrointestinal problems that NSAIDs have, right? Or for instance, having an H1 blocker versus H2 blocker. When I say H, what does that refer to? Yeah, histamine is actually what that's referring to. So we talked about Benadryl the other day, right? Anyone know which histamine receptor that blocks? If you ever hear of an H1 blocker, that's what that is, right? It's an antihistamine used for allergies and things like that. We also have H2 blockers, and those are primarily found in the gastrointestinal tract, mainly in the stomach, right? That's responsible for causing a lot of acid production. And so we can have drugs that are specifically just working on H2 receptors to block those and hopefully help to deal with things like GERD. It's like Zantac or Pepcid, drugs like that actually are affecting H2. Again, don't worry about if you don't know the drugs. We'll cover those in greater detail later on. There'll be time for that, right? Just trying to illustrate the points. In some cases, we actually find that we get new therapeutic uses for drugs based off of weird side effects that we found when we were originally testing them. So has anyone ever heard of the drug Rogaine or minoxidil? Well, originally that drug was used systemically as an antihypertensive. However, they found it was pretty crummy as an antihypertensive. But when they were given to the people, they said, wow, look at this hypertrichosis. Look at all this hair growth that these people are getting. What if we used it in another way? So they started rubbing on people's heads, and all of a sudden, started to grow some more hair. Right? So again, it's kind of serendipity, right? You find kind of an unintended effect, and you can now use it for that particular purpose. Anyone familiar with the drug Latisse? What is that used for? Well, so originally it was used for glaucoma, but what did they realize that it does as well? Gives these beautiful, long, luscious lashes, and they said, well, let's use that therapeutic. Let's use it, for aesthetic purposes. So it was a nice side effect for people who had glaucoma, but now we're actually using it for more cosmetic purposes, right? You can also turn your irises brown, so sometimes it's not good if you have nice baby blues or whatever, but we'll talk about that later on. Yeah, there's always pluses and minuses, right? But anywho, point being is that based on sometimes odd side effects, unintended effects, we get brand new therapeutic uses for these drugs here, right? Those are just a few examples. And so typically, when we're giving a drug to a patient, you have to consider all the ancillary sort of effects there, whether it's through the same mechanism, through different mechanisms, and try to hopefully limit the toxicity as best you can while maximizing that therapeutic effect, okay? That's going to help you determine kind of which drug is going to be better for a particular patient based on these sort of conditions here, okay? Again, just because a drug is super potent or just because it's very efficacious does not mean it's necessarily better than another drug who is maybe less potent or less efficacious, right? Because there's a lot of other factors that go into it. So any questions on that? If not, let's move into the next section. So now we get to talk about the pharmacokinetics. So anyone remember what pharmacokinetics refers to? What the body does to the drug, right? So again, we're saying like, well, how does the body actually handle medications? And so we'll break this up into four main sort of categories. And so it's A, D, M, and E, which is going to be absorption, distribution, metabolism, and elimination. We'll find kind of where, how the body is going to be interacting with these drugs at all four stages of this in this section here, okay? So we'll also cover things like loading doses, we'll talk about steady state, and then also talk about how these can contribute towards toxicity from some of these medications. Now, normally what happens after we give a drug to a patient, you're going to find that drug will be liberated, or say if it's like in a tablet, it'll dissolve and go into solution. It'll then be absorbed. Most of the time when we talk about absorption, where's it going to be coming from? Mostly the GI tract, right? We're thinking about absorption through this, sometimes in the stomach, mostly in the small intestine. What organ is going to hit first, do you think? Probably the liver, right? So again, most things that get absorbed from the GI tract tend to go to the liver first for the most part, not completely. But what you find is that it's going to be really important in terms of how we're absorbing drugs. We talked about first pass effect, and we'll cover that again in just a little bit. But essentially, once that get absorbed into the central circulation, or basically in the bloodstream, you now have free drug. And the question is, well, what happens to the drug after that? Well, some of it's going to go to the therapeutic site of action, wherever they may be. Could be in the pancreas, could be in the brain, could be anywhere, right? You're going to find that some of it will be bound within the tissues, and you can build up tissue stores of medications potentially. And then, of course, unwanted side effects could be occurring as well with this. Some of the drug is eventually going to make it to what we call biotransformation. Anyone know what that might mean? Your body's transforming it. Basically, it's metabolizing. When I talk about drug metabolism, that's biotransformation essentially. What are we changing in the drug to get ready for it to be eliminated from the body, okay? And then eventually we're going to get this concept of excretion. So where do we excrete drugs from? Anyone know? The kidneys are going to be one of the main sources, right? So we can eliminate drugs through the kidneys. Where else might it be eliminated?
GI.
Yeah, so how does it get into the GI tract? That's the question. Actually through the biliary tract, right? You'll find drugs can be metabolized in the liver and then actually get sent out along with the bile, right? So those are two of the big ways that we can excrete drugs. In some cases you can actually exhale metabolites of drugs, that's a kind of a minor one, but those are the main ones. So mostly you'll find metabolites of drugs either in the feces or going to be in the urine, okay? And we'll get into talking about that in more detail in a minute here. That's kind of the main gist of things. But starting off, how do we actually get drugs absorbed into the body, right? Now, we talked about bioavailability, and which route of administration always has 100% bioavailability. IV is always going to have 100%, right? That's going to be the fastest way because it goes ahead, or it'll go ahead and go straight into the central circulation. You don't have to worry about first pass effect. You don't have to worry about it not going to the GI tract, anything like that. So again, that's always kind of our baseline. Well, let's talk about how things actually get absorbed from the GI tract, how it's going to get absorbed through mucous membranes, things like that. And so essentially what we're talking about is just general permeation, right? We're talking about passive diffusion of substances across biological membranes, okay? kind of the core of what we're getting at. Now, when I say passive diffusion, what does that mean? Yeah, kind of basically things going from an area of what concentration? High concentration to low concentration. All right, so everyone's probably done this, and they're like, Bio 1 classes back in undergrad, right, where you had like a semi-permeable membrane, you put like some food coloring in, and then you see it kind of diffuse out. That's essentially the same process we're having here, right? Now, does this require any energy to occur? No, right? That's why it's passive, right? So it's a very efficient way to get things across. But again, it's important to know some of the factors that will actually drive some of this absorption of medications here. Now, when I say a biological membrane here, what do you notice about this membrane? Anyone remember the name for that? The phospholipid bilayer. What does that mean? It's hydrophobic and hydrophilic. Which one's which? Anyone remember? Yeah, so it's going to be more hydrophobic in the middle here, and then more hydrophilic on the outside here, right? Because this is where it's actually interfacing with the water, right, of your body. And the inside here is a little bit more fatty, right? This is more lipophilic. So the question is, well, do I want something? What's going to be easier to cross? Something that's lipophilic or something that's hydrophilic? Generally, lipophilic stuff is going to have an easier time crossing, right? That's why it likes fat, so it can get across these membranes here, and it's going to be able to be absorbed, okay? So we'll talk about lipophilicity, we'll talk about hydrophilicity and all those things in more details as well. Anyway, so again, and we'll talk about aqueous and lipid diffusion here. The same processes are going to be basically applying, though, is that one, we're having things go from an area of high to low concentration, and this is a passive process requiring no energy. We'll see there's some active processes as well here. Now, one of the big things you're going to find is that we can actually change how lipophilic a substance is based on the pH of the solution that the drug is in, and also on the pKa of the drug itself. Now we're going back to your basic chemistry. Does anyone remember pKa? Anyone remember the Henderson-Hasselbalch equation? Yep, that's coming back to bite you in the butt. So if you've repressed those memories, you're going to be triggered by this, but we're going to talk about it briefly, right? And again, there's very little calculations that are going to be going on here, but we'll talk about the concepts that go into it to determining how well does a drug get absorbed, essentially. So looking at this, other ways we can get things across include carrier-mediated diffusion, right? So for things that cannot get across the membrane on its own, say for instance it's too hydrophilic, some molecules are just too large to go across on their own, there are ways we can still get them into our cells. And this is where we can have carriers that can help with this. Some of them may go along the concentration gradient. Some of them can actually go against the concentration gradient, right? And so at that point, what does it require? Energy to go against the concentration gradient. So if you guys have I assume have covered the sodium-potassium ATPase pump before, right? What does that do? Sends sodium in or out of the cell? Out of the cell, and brings potassium into the cell, right? Because that's against the concentration gradient there, right? And that requires ATP to actually function. Now, is that a very important transporter? Yeah, because your heart would not work without it, right? Your neurons would not work without it because it maintains that normal electronegativity for action potentials to occur, right? So again, these are important processes, but just know they do require energy and they can go against that concentration gradient. Other thing to note as well is whenever you have carriers like this, they can become saturated, right? So it means as long as you have enough drug to kind of fill all of those spots up, it will limit how fast that can actually occur there. With diffusion, typically the bigger the concentration gradient difference, the faster the diffusion is going to occur. There's really no limit on that for practical purposes. So anyway, so as we mentioned with aqueous diffusion, this is going to be happening with a lot of the larger aqueous components of the body. Mainly we're talking about the serum, right, the central circulation of the blood supply, and then transitioning over into things like the interstitial fluid, and then eventually getting into the actual intracellular fluid itself, right? Again, we can find things like can actually squeeze through some of these aqueous pores that happen in the endothelial lining, right? So they can actually get through from the bloodstream into the extravascular space there. And this is governed by something called Fick's law. Has anyone heard of Fick's law before? You're going to say, Fick, I forgot that law. No. Okay. No. And again, don't get scared by the variables or anything like that. I'm not going to actually have you calculate any of this stuff, but it's good to know the concepts of what, if I modify any of these variables, what is that going to do to my absorption of a product, right? And this can actually be applied to some of the lipophilic stuff we're going to talk about in a second, some of the lipid diffusion. But essentially what it comes down to is that flux, or how much of a drug is going to be crossing that membrane, is going to be based on several things. So one's going to be the concentration gradient, right? So how big of a difference do I have between the outside to the inside? If I have a very large difference, what is that going to do to flux? It'll go up. I'll have more drug crossing over, right? What happens if I have a very small gradient? It's going to go down, right? Because again, it's pretty close to being at homeostasis anyway, right? It's being pretty close to being at equilibrium. It's not going to have a whole lot of flux at that point. But if I have almost no drug on the inside and a lot of it on the outside, you should get a decent amount there. The next part here is going to be area. So the area of the membrane that actually has to cross over. So typically, if area goes up, what happens to your flux? Should go up as well, right? Because it's in the numerator. So if the area that I'm covering is goes up, you're going to find better absorption. So that makes sense, right? When you think about the GI tract, is the GI tract just kind of one long hollow tube? It's all nice and flat and smooth? No, there's all this villi and all that kind of stuff. That increases the surface area of the GI tract exponentially, right? We have a lot of surface area down there, and that's really important because that increases the amount of contact space that the drug can get in contact with the GI tract to be absorbed. Important for nutrients, important for things like that. In fact, if you had someone who had, say, a chronic inflammatory bowel disease like Crohn's disease or something like that, they can actually lose some of those villi and they can have problems absorbing things because they lost that surface area. So that's another important concept to consider for flux here. Next off is the permeability coefficient. This is essentially how lipophilic or how easily a molecule can cross this membrane here. Typically, the more lipophilic it is, the easier it's going to be able to cross some of those membranes, and so that will also increase flux as well. Okay. Sometimes things can be so impermeable that it doesn't matter how much of a concentration gradient I have, it's never going to cross over. So just know that some things are going to be very, very impermeable. Some things are very, very permeable. We'll talk more about that in a little bit. And then finally, think about the thickness of the membrane itself. So the thicker the membrane I'm trying to cross, it's going to make it harder or easier to get over. It's going to make it more difficult, right? So for instance, imagine this comes up a lot. We'll talk about when we talk about dermally applied medications there. Where do you think you'd have better drug absorption coming from if I applied, say, a cream to, say, your armpit versus the sole of your feet? Probably your armpit, right? It's a lot thinner skin. It's a lot easier to cross over because it's less thick than would be the sole of your feet. We have all those calluses, and it's kind of hard to get across that epidermis, right? So again, that can make a really big difference here in terms of how well that flux occurs. So, and you get thinking like, why do I even care about this stuff? Well, clinically, it does actually matter. So I'll give you an example here of a case that we had one time. So we had like a 10-month-old infant who was, at home, was having a lot of diaper rash, and was really kind of having like some flame sort of, butt and crotch and all that stuff. And so one night, the mom was washing the baby, right? So nice hot bath, and took the baby out and was going to go ahead and apply some diaper cream to the baby, right? And so the dad happened to have a lot of chronic back pain issues, and he actually had this specially compounded back cream that he had made for him. And it had things like ketamine in it. And with ketamine, it's like a dissociative anesthetic. Like we use it to like knock out people so we can set their bones and things like that. It had antidepressants in it. It had all kinds of different products into it. And so what happened, mom thought she was grabbing the Desitin and instead accidentally grabbed this stuff and applied it to this nice inflamed skin. Now, do you think a baby's skin is pretty thick or pretty thin? Very thin. So they applied to that and then actually applied an inclusive dressing in terms of a diaper over that. And so guess what happened to that absorption? It was very good because, again, very thin skin, had a lot of good blood flow to it. The skin was hot, it just absorbed a ton. So they went, laid the baby down, came back in, realized the baby was not responsive. So they went ahead and called 911, got the baby in, and had to intubate. Baby did fine in the end, but they were able to draw blood levels from the baby and actually found detectable levels of a lot of those medications in the blood there, because everything was set just right for that baby to absorb a lot of that drug versus an adult who probably would not get that same absorption. Make sense? So a lot of surface area was being covered. There's a big concentration gradient, and the thinness of the skin really was kind of going against the patient's favor there. Okay, so just an example of how this can come up clinically potentially. Okay. So anyway, I'll show you a picture that kind of illustrates some of this as well. But again, just know faster diffusion and absorption will happen with larger gradients here. You're going to find that things that have a large surface area are going to get absorbed better. Thin membranes are going to get absorbed better. And then also you're going to find that the lipophilicity of the drug will be the thing that determines that permeability coefficient there. Okay. So this picture kind of gives you that example there where the thinness or the thickness of the membrane, the area we're covering, and also the concentration gradient makes the biggest difference here. Okay. All right. So again, looking at these lipid layers here, you're going to find that pH can actually have a big effect on how well drugs can be absorbed here. So we're going to talk about ionization. We'll talk about ion trapping, all kinds of stuff here in just a minute. But basically, what's going to come down to is that the pH of the solution that the drug is in is going to dictate the ionization state of that drug. And you're like, well, what the heck does that mean? Basically, it means that if a drug picks up a charge on it, So if it goes from having no charge to having a positive or negative charge on it, you're going to find that it becomes more lipid or water soluble, do you think? More water soluble because it's more polar now, right? So if it has a charge on it, you're going to find it's going to have an easier or harder time getting across that lipid membrane. Harder time, right? Because again, it's more polar, it's going to have a harder time, it's more hydrophilic, it's more lipophobic, has a hard time crossing over, okay? If a drug is uncharged, so it either picks up or drops off a hydrogen ion and it loses that charge, it's going to have an easier time crossing over because now it is less polar, it's more lipophilic, okay? Everyone with me so far? I'll show you some variables here in just a second, see how we can modify this. But how do we determine how much of that drug is charged or uncharged? Well, it comes back to the pKa of the drug itself, right? Now you guys are familiar with the term like weak acids and weak bases, correct? Well, most of these drugs are going to fall into one of these two categories, either weak acids or weak bases. All of them are going to have a pKa, though, that we can associate with those drugs. And depending on the solution that we're putting it in, the pH of that, we can modify this pretty greatly. And again, if you think about it, like what's the pH of, say, the stomach acid? It's around 2 actually, right? So it's very, very acidic versus, say, you get into the small intestine, your pancreas is spitting out a bunch of sodium bicarb. What happens to the pH there? It's going to get more alkaline. It's pretty close to being neutral, 7 to 8 or so. Okay, so you can already see that depending on where the drug's at within the GI tract, the pH of the solution that it's in can change very greatly, right? And that will change the ionization state pretty drastically, as we'll see in a moment here. Okay, but anyway, we're going to find this gets described by the Henderson-Hasselbalch equation. So essentially some of the nomenclature that I'm going to be using to describe this is one, pKa is that acid dissociation constant. A handy thing to remember is that if the pH of a solution is equal to the pKa of the drug will be 50% ionized, 50% unionized. 50% of it will have picked up a hydrogen ion, 50% of it will have dropped off a hydrogen ion. And again, this is an equilibrium, right? You'll find that the drugs are going to be in equilibrium of picking up and losing those hydrogen ions. Because again, what makes a solution acidic? How much of the hydrogen ions are present, right? The higher the concentration, the more acidic the solution gets, and I'll show you what this looks like. And again, I will link this back to a clinical example of why this matters, okay? Because again, a lot of you are probably like, who cares? It does actually matter, right? And I'll show you some examples of that. So the nomenclature here, if you have a protonated acid, this is going to be in the uncharged state, right? Normally the acid, if it does not have that extra proton on there, you're going to find it's just going to be in the A- sort of state. And then again, it's going to vacillate between these two depending on the pH of the solution and the pK of the drug itself. Once it picks up that protonated that proton there, it's going to become uncharged. So which one of these do you think would be more lipophilic? The protonated uncharged form of that acid gets absorbed more easily, right? Because again, we said once you lose that charge, it becomes more lipophilic. You can absorb it easier, right? Okay. The flip side of that is also going to be true as well for a base here, a weak base. Normally, when it loses that proton, it is in the uncharged sort of state. Okay. If it picks up a hydrogen ion, now it becomes positively charged. Okay. That's going to have a harder time crossing over. It's going to be more hydrophilic at that point. Okay. So what situations do you think I'd have a lot of hydrogen ions around that would protonate this acid here? In a more acidic or more alkaline solution? More acidic, right? So we're saying here that weak acids get absorbed easier in an acidic solution. Interesting. So would you say like dissolves like? Anyone ever heard that before? Same thing applies here, right? So weak acids tend to get absorbed easier in more acidic solutions. Okay? The flip side of this is also going to be true here as well with the bases. If a base loses that proton, right, if it's in a solution with fewer hydrogen ions around, like a more alkaline solution, it's going to be more in this unprotonated, uncharged state. Guess what? It gets absorbed a lot easier too. So weak bases in a basic solution will also get absorbed more easily. Again, like dissolves like. Go back to that if you're ever confused, and that will make a little bit more sense of this stuff, hopefully. Okay. So why does this matter in terms of drug absorption here? Well, let's look at a weak acid first here. Again, remember this is an equilibrium between these two states, right? Depending on the concentration of hydrogen ions, you'll draw this equation one direction or the other, right? So if I put the weak acid into a more acidic solution, it's going to pick up more of these. You're going to have a higher percentage of that weak acid in this state. It's going to have a much easier time getting across. Okay. The flip side is also true, where if a base is in a more basic solution, more alkaline solution, you're going to find something more in this state here, and it gets crossed over more easily. If it has a charge on it, you see it just bounces right off. No absorption really happens at that point. Okay? Everyone with me so far? So why does this matter, right? So, well, what if I had, say, a drug cross over into another compartment that had a different pH than what it was before? You can actually have a case where, say, a drug will cross over to a membrane, it gets it put into a different pH solution, and guess what? It actually gets more into this charged state, and it can't cross back over. We call that ion trapping, or basically a drug will get concentrated into a particular compartment where it can't get back over because the pH has changed. So this actually matters for nursing mothers. Why do you think that is the case? Well, the pH of the breast milk is a little bit different than what it is in the blood supply for that patient, and so because of that, they can actually trap drugs into the breast milk. And why does that matter? Because that means that the baby might be exposed. I was going to say the fetus, but not really the fetus at that point if they're breastfeeding. But the infant will then be getting exposed to that medication there. Now, is that a good thing or a bad thing? Typically not preferred, right? If we can avoid having drug exposure in children, that's always going to be preferable, right? A lot of times we don't know what they're doing in these kids and things like that. So that's one of the big concerns, right? So we have to tell mothers, like, how do you take these medications to avoid having that occur and, exposing your kids to all this medication and stuff, right? Alcohol can do the same thing, right? That's why we talk about the pump and dump strategy. You ever heard of that? Right? So that way mom can still have a few drinks, because, I mean, she's gone 10 months. She deserves a drink, okay? She's presumably just passed a person through her body. Let her have a drink, right? So there's strategies we can actually get around some of this stuff to avoid having this undue exposure to those babies there, right? If you don't know what I'm talking about, there's some good mommy blogs you can check out as well. Anyway, so getting into the actual equation itself, what this means is that the pH of the solution will equal the pKa of the drug itself plus this log of the non-protonated to protonated species, right? So again, I'm not going to have you calculate this. There's no logarithms I want to have you do on the test. That would be exceptionally mean to do that. But basically what this is trying to describe is what's this ratio between the non to the protonated state here, right? So again, with a weak acid, you're going to find that by putting it into a more acidic solution that's in a higher amount of protons that are around, you're going to be favoring this form here where it's going to be absorbed much more easily, right? For bases here, if I put it into a more acidic solution, you're going to be putting it into that protonated form where it's not going to want to be absorbed very easily, okay? So the question is, like, where else might this matter clinically? And I'll tell you that as my job as a toxicologist, this actually comes up frequently. So does anyone know what the abbreviation for aspirin is? ASA. Does anyone know what that means? Acetyl salicylic acid, right? So if you had to guess if it's a weak acid or base, what would you guess? It's a weak acid, right? Okay, so aspirin presumably gets absorbed more easily in an acidic or a basic solution? Acidic, because we said like dissolves like. So weak acids like to be more readily absorbed into an acidic solution. Okay, so let's say I have a person who decides to overdose on a whole bunch of aspirin. They take just whole gobs and handfuls of the stuff, right? So based on what we talked about, do you think it'd be more easily absorbed in the stomach or the small intestine? Actually, in the stomach, you find a little bit better absorption of aspirin there because it is more acidic, right? So the patient's absorbing a lot of this aspirin here. And aspirin, if you don't know, can be a very, very dangerous overdose, right? It's one of those ones I get a little scared about when I hear someone have overdosed on a lot of it. I've seen some really bad cases. But point being is like, well, if I want to get this out of the body faster, how can I do that? And so this actually goes to talking about elimination of the drug. But essentially, aspirin gets eliminated through the kidneys. So if the aspirin is in the renal tubules and it's in this more protonated state here, say the urine's a little more acidic, say it's a pH of 5 or so, it's going to have an easier time getting reabsorbed, right? So it'll get filtered through the glomerulus, it'll be reabsorbed and back into the body. Now, is that what I'm looking for in that patient there? No, they got too much aspirin to begin with, right? I'm really worried about that. So what can I do? Well, I can actually alkalize the urine, put the pH higher, and it's going to favor the aspirin being in this state here, where it is going to be charged but non-protonated. So what does that do to the reabsorption of aspirin? Bounces right off that renal tubule and they pee it right out. So I can actually give sodium bicarbonate in the blood to alkalize the urine, and that will allow for the patient to eliminate that aspirin faster. Okay, and again, it's something we do day in and day out at the Poison Center because it is a very effective way to change the pH, change the ionization state, and get rid of that drug that much faster. Okay, make sense? If not, it's okay. At the videos, you can go back and listen to my dulcet tones over and over and over again. That'd be great. Anyway, so another graph to kind of show you this example here is that, again, when the pH is equal to the pKa, you're going to have this 50-50 sort of ionization state where 50% of it's ionized, 50% unionized. And by altering that pH, you're going to see you can favor one form or another, okay, depending on the drug that you're dealing with, okay? Now, and again, you might think like, well, clinically, why else would I ever care about this? And this can be a big factor. So, for instance, if you're looking at, say, an older patient, right? In older patients, what element do you want them to get a lot of in their diet? Calcium. Yes, you do want them to get fiber. That's not really an element. But yes, everyone should get more fiber in their diet. That's in general. But calcium is really important, right? Because calcium is useful for staving off what? Osteoporosis, and if they fall, they have osteoporosis, what are they more likely to have? A fracture, right? So again, all kinds of bad stuff. So you tell these patients, hey, eat your calcium, right? Drink your milk, whatever the case may be. Well, and a lot of these older patients also suffer from GERD, right? So they have a lot of overacid production, and so it's causing a lot of problems. And so you may have a patient who is taking a drug to block acid production in the stomach. It fixes their GERD symptoms, but you actually find that calcium is less absorbed there. Calcium likes to be absorbed in more acidic solutions. And so in those cases, you actually find that patients, they're taking a ton of calcium, but guess what? It's not really getting absorbed at all. It doesn't do them any good. So there's a lot of drug interactions you run into where by modifying the pH of the GI tract, you can modify the absorption of these drugs pretty significantly, right? Because calcium is a drug just like anything else. But again, just remember in an acidic solution, you're going to find weak acids get absorbed more easily. Weak bases are going to be less likely to be absorbed there, right? So morphine's an example of a weak base. If you were to put it into that acidic solution, it's going to have a harder time crossing those membranes because more of it will be charged. And again, you'll find that every drug has its own pKa associated with it. Now, do you think clinically you're ever going to look this up? If you are, you're barking up the wrong tree most likely, right? But again, we are formulating a lot of these things so that way we can allow it to be absorbed based on the type of dosage form that we're giving. Has anyone ever heard of like enteric coating of something, right? What does that mean? Protects it from the stomach acid, right? Because some drugs actually get destroyed in the stomach acid. And so by doing some of these things and actually changing the dosage form, you can try to overcome some of these problems here where it can be absorbed a little bit more easily. So just know that every drug will have one of these factors here. And again, you're not going to be looking these up, but inherently I want you to kind of know, okay, well, if I'm modifying some of these factors here, how's that going to affect my absorption, right? All right, so moving on, that was just mainly passive diffusion we're talking about there, but getting into more specialized carriers, again, you're going to find that we have a lot of these. Some of them are designed to bring substances into the body or into certain compartments. Some of them are designed to push things out, right? So we have efflux pumps that can actually get things out of certain compartments there. So for instance, the blood-brain barrier, some of the people who are familiar with that term, what does it do for us? Keep stuff out essentially, right? Toxins and bacteria and all kinds of stuff. So it's kind of like the bouncer for the VIP lounge of the body. I kind of think about it as like, nope, you're not getting through here, right? Well, we have certain transporters that really help with that because some drugs will just absorb across anyway, but we'll have transporters that will kind of pump them back out, right? You can also see we have similar transporters in the renal tubules that will be responsible for either reabsorbing or secreting substances as the case may allow for. And basically, this is good for things that maybe can't cross membranes on their own. Perhaps they are too large to cross on their own. And just know that they are not governed by fixed law. So if I can have a huge concentration gradient, but if I'm saturating all of those transporters, there's no more flux that's going to be happening there, right? Because again, they're all saturated, they're all taken up, they can only work so fast. And again, a lot of these tend to require energy because again, they're usually pumping things against concentration gradients. Just know that they can go against the concentration gradient. Anything governed by fixed law, like we were just talking about, has to go from high to low concentration. Make sense? So just to give you an example, here's one called the MDR1 drug exporter. So this is a form of an efflux pump. And basically this is a special one that is used for getting things out of certain compartments, right? So this is located within the GI tract. This will actually pump things out of the body. You may absorb back into the GI tract. This is located on the blood-brain barrier that will kick things out of the CNS back into the central circulation. Another name for this is also called P-glycoprotein. If you ever hear PGP, that's what that's referring to. So to give you an example, anyone ever heard like don't drink grapefruit juice with certain drugs? This is one of those cases there, and I think I mentioned this before. But basically statins, and I don't know what you use a statin for. For cholesterol, yeah. So things like atorvastatin, simvastatin, rosuvastatin, some of those are affected by this MDR1 transporter or this PGP protein. And basically what it does is it'll get effluxed out of the body back into the GI tract where it can be eliminated in the feces, right? Well, I can give grapefruit juice to those patients, and that will inhibit that pump. So what do you think it does to the levels of drug within the body? It actually will build up, right? So levels go up, and one of the things you'll find with statins, when the levels get too high, they can cause hepatotoxicity. They can also cause muscle breakdown. And what other term for muscle breakdown is? Rhabdomyolysis, right? So if you ever have someone who is, say, for instance, taking a statin and they're drinking grapefruit juice, right? Or they call up and they say, hey, man, it feels like I just ran a marathon. I've just been sitting on my couch all weekend. And they go to the bathroom. What does the urine look like? Anyone know? looks like dark cola or dark tea, something like that. It's all the myoglobin getting out to the kidneys, right, and being excreted in the urine, and that's a bad sign, right? It shows that the muscle's being broken down. You got to do something about that immediately, right? So anyway, but that could be an interaction there. By inhibiting that transporter, you keep more of the drug in the body, levels go up, and toxicity is going to be more likely. Okay, so again, that's how some of these transporters are going to be working here. You also find some of them are located within hepatocytes. They can actually spit drugs out into the bile. So I mentioned that's also one way we can eliminate drugs as well, is by spitting them into the bile, then they can be eliminated in the feces as well. Here's an example of what it looks like on the enterocytes, where again, it can spit it back out, so that way we can get our levels down. Okay, another process we have, endocytosis. What is this? It's like the cellular hug of death, I call it. They're just kind of like sends out these little podocytes and just kind of engulfs something, right? So again, usually if substances are too large or maybe lipid insoluble, basically it just forms a vesicle around it and then it can incorporate it into the cell, where it can then be shuttled off somewhere else potentially. Again, some cases where this happens is going to be things like absorption of B12 with intrinsic factor. Things like iron gets absorbed through this way with the product called transferrin. So again, it's a less clinically common, but it's something that's just another way that drugs can be absorbed potentially. And then exocytosis is what? Kind of cell is expelling that vesicle now and kind of getting rid of it. So a lot of natural products get released this way, so like neurotransmitters, insulin, all kinds of different things, because normally we'll have these little vesicles in the cells kind of storing those products, and then they can undergo exocytosis and kind of get rid of them at that point. It's a lot of hormones and calcium and things like that. Again, this picture kind of just showing what that looks like. Exocytosis kind of releasing things and eventually taking them back in through these vesicles here. Okay. All right, so let's do a 10-minute break. We'll come back and then get into distribution. Okay, let's look at the questions here. Okay, is this what House had, rhabdomyolysis? I'm not sure. Actually, I don't watch much House. Can anyone confirm House had rhabdomyolysis?
He just had muscle neck, like the legs and the muscles in his leg, like the muscles were dying, and so that was the pain. So that's why he was addicted. But they never said during the show like why it happened.
Interesting.
So I would just
Who can say? Yeah, I think it's usually more of like an acute sort of process. Normally it's not like ongoing, but who can say, right? I'll have to go watch that show now. Great, thanks. Thanks for my homework. No, just kidding. Okay, what's the difference between epi for anaphylaxis, dilation, versus epi for vasoconstriction? That's a really good question, actually. So what you're going to find is that when you have anaphylaxis, what are some of the things, like physiologic changes that actually occur? Your throat sort of swells up, right? Why does it swell up? It's due to fluid, right? So it's edema basically happening there, right? So you're filling up that tissue with lots of fluid. Well, where's that fluid coming from? From the bloodstream, right? So if I can constrict down on those vessels by giving epi, that can actually help to limit that fluid that's there, right? So that will help to open that up. It also, when you're looking at the different effects there, so epi will hit alpha-1, so that will cause vasoconstriction or dilation. Causes vasoconstriction, right? So that helps the blood pressure come back up, because frequently those patients get hypotensive, right? And then the other thing you'll find is that it allows for beta-2 activation, and beta-2 normally does what? Smooth muscle constriction or relaxation? Relaxation. So now the lungs and the bronchial smooth muscle and all of that is actually tightened up during an anaphylaxis or anaphylactic event can actually relax, right? Just like I give albuterol as a beta-2 agonist, epi is going to do the same thing essentially, right? But again, I don't want to give epi for someone with an asthma attack because all the other ancillary side effects due to that mechanism there. That kind of makes sense? We'll talk a lot more about that in the poem section later on. But yeah, so basically we're doing it for kind of both purposes there. Okay, which of the bases is more lipophilic, BH plus or B? If it is B, then how does BH plus pass the membrane? Remember, it's an equilibrium, right? So not everything is going to be 100% ionized or 100% unionized unless the pH, you're at really extremes of the pH, either 1 or 14. So in those cases, you're going to find that some small amount of it can cross over, depending on what the ionization state is, and that may aid in the speed of it or slow it down depending on what that sort of ratio is, right? And that's what the Henderson-Hasselbalch equation basically says, is describing what that ratio is from the protonated to the unprotonated species, right? Or vice versa, unprotonated to protonated. Does that make sense? That answer someone's question, I hope. If not, you can post another question on the board. Fantastic. Okay, let's get back to our topic at hand, which is distribution. So we talked about how things are getting absorbed into the body and how they cross membranes. Now let's talk about where they're going to go to, right? So we get something absorbed into the bloodstream. Where does it go from there? Brief answer is kind of everywhere, but you can find that it can actually differ depending on a lot of the physiochemical properties of those medications there. So one of the terms we use is called volume of distribution, right? This is essentially sort of a theoretical sort of number, but it's trying to tell you how far distributed does that drug get out throughout the body, right? So does the drug like to just stay within the bloodstream and just kind of hang out there? That's going to have a relatively low volume of distribution because it's not really going very far. Versus if it partitions out and say goes into the fat tissue, goes into the muscle, goes into the brain, if it distributes out far, then that would give you a high volume of distribution, okay? So basically we're just trying to describe that feature there. Now, what type of drugs do you think? Hydrophilic or lipophilic drugs would have a higher volume of distribution, if you had to guess? Lipophilic drugs, right? So lipophilic substances like to partition out typically because why? Like, well, because they have an easier time crossing all those membranes, right? So they can go into places like the adipose tissue, which presumably is pretty fatty, right? And is going to be able to hang out there, and that's totally fine. So if I talked about THC in this class yet, as an example, so I always see like yeses and nos, and I'm like, okay, so someone's either making up false memories or has already forgotten. Who can say? I will reiterate the point. So, so anyone familiar with THC or tetrahydrocannabinol, delta 9 THC, is the main psychoactive component of what? Marijuana, right? So again, that's what gives you the euphoria, that's what gives you the high. Now, that substance, does anyone know if it's lipophilic or hydrophilic? Lipophilic, right? So where do you see THC being used in terms of, say, for instance, like cooking? Brownies, butters, oils, pizza, like different things like that. Usually a lot of fatty sort of foods, right? So it stands to reason that THC is actually pretty lipophilic, right? That's how you can incorporate it into those things like your butters and oils and whatnot. So, so we know that THC is lipophilic, right? So how might that matter clinically for a person? Say, for instance, you were applying for a job. Yeah, so the question is like, well, how long might someone be positive for a urine drug screen for THC? That one's really, really tough. Like certain substances, I can tell you pretty definitively how long it's going to stay in your system for. Like cocaine, probably 2 or 3 days. You can detect that, right? Marijuana actually matters pretty greatly because it has such a high volume of distribution, which means it is very fatty, so it likes to go into to these tissues, and it likes to hang out into the adipose tissue. Okay, which means that it can just kind of build up levels there, especially for someone who's smoking or ingesting THC chronically, especially at high doses, likes to build up in the fat tissue, and then it will slowly leach out over time to where someone can stay positive on a urine drug screen for really chronic users, for like, not users of the chronic, but chronic users, you see it for 6 weeks up to several months, right? 2 months potentially. And because they just have all that amount that's kind of hanging out there because it has a high volume of distribution. That makes sense? So again, someone might come up and they say, well, how am I going to show positive? I got a drug screen tomorrow. The question is really difficult to say, right? So I had one friend when I was doing my fellowship in toxicology, so I was learning a lot about this stuff. And I had one friend who was like, I need to know. Like I went to Colorado and I might have used a little bit and I just need to know if I'm going to be positive or not. And they were a relatively thin person. They did it one time. I was like, no, you're probably going to be good, right? So versus someone who was, say, smoking a ton and they had a lot of adipose tissue, they would probably be much positive for much longer, right? That makes sense? I think it goes back to the volume of distribution of these substances. Good question.
Yeah, is there like a characteristical, or like if THC is lipophilic, is there something else that we could use to associate to
something more hydrophilic? Yeah, so for instance, like cocaine, right? You have people who are using cocaine quite frequently, but again, they only stay positive for, say, 2 or 3 days because we are able to keep that in the bloodstream. It gets broken down pretty easily and then gets eliminated very quickly, right? So one time someone told me on a urine drug screen, was like, yeah, the only way you can get positive for cocaine is if you do an 8-ball out in the parking lot. Not really, right? You guys know what 8-balls are. We'll turn safe search off and then you can look it up. But anyway, point being, it's a lot. You know, it's cocaine. It's a unit of measure for cocaine. But anywho, it gets out of the system very quickly, and that goes to talking about how sort of hydrophilic the substance is versus something more lipophilic like THC, right? Now again, I like to bring stuff back to illicit substances because one, I think they're fun and it sticks in your mind a little bit better, right? So they kind of illustrate the points here, right? Hopefully. Anyway, so every drug, though, will have a volume of distribution associated with it, right? Because we can actually measure this sort of thing. And the way we're going to measure that is basically based off of looking at the dose of the drug that we give a person and then the actual level that we can measure out of the person, right? And what's the easiest way to measure a drug level in a person? So you can do it in the urine, right? But that's usually drugs getting ready to be eliminated. Okay. So you can check for exposure in the hair, but usually the blood is the best way to determine how much drug is kind of in there in the body right now, right? Because again, that's what's actively being circulated. And so we usually take the dose that we have that were given to the patient, and then we'll actually measure the level, and depending on what that level is, that will inform what the volume of distribution is. I'll give you some examples of what that looks like in a second. So looking at this, how might you actually calculate it? And again, I'm probably not going to have you calculate this specifically on the exam, but I want you to know if I were to change any of these features, how might that affect the volume of distribution for a particular drug, right? Because there's lots of different disease states that can actually affect this. But essentially, what you find is that volume of distribution, which is measured in liters, right? It's kind of an apparent volume, and liters is volume. Basically, it's the amount of drug that we give in milligrams, most typically, divided by the concentration in the plasma, right? So what do we actually measure if we were to take a blood sample and measure that amount? That's usually in milligrams per liter. You might see in micrograms per ml, milligrams per deciliter, but most commonly, at least for our purposes, we're going to stick with milligrams per liter. So what does that give it? What does that tell us? So if I were to give someone, say, 500 milligrams of a drug, and I were to measure that blood sample to see what volume, or see how much was there, that will tell me, is a lot of it still sitting there in the blood, or did a lot of it partition out into the tissues? Just to give you an example here, right? So let's look at an example where I give you 25 milligrams of a drug, and then I check the plasma concentration relatively soon after, and I get this concentration of 5 milligrams per liter. Okay, so what does that tell me? And again, unless I specify otherwise, just assume I'm talking about IV administration, because that means what in terms of bioavailability? 100% right. We'll get it more complicated later, right? But in terms of right now, if I just don't specify, it's 100% bioavailable. So anyway, so I would measure that, and I would get 25 milligrams divided by 5 milligrams per liter, and that would mean my volume distribution is 5 liters. Now, of course, you don't have any clinical context for that to know, is that a lot, is that a little bit, and I'll go into more of that in a second here. But generally, something that has a higher volume of distribution tends to be more lipophilic. Kind of a general rule of thumb there, right? So again, this is very lipophilic. Generally, that's a high volume distribution. If it's more hydrophilic, it's a low volume distribution. Yes, ma'am. Depends on the drug itself. We can actually, it gets complicated. We can actually back calculate some of these things, right? So again, we know drugs get metabolized over time, so typically levels will go down over time. And if we know how they're actually metabolizing and clearing it, we can back calculate to when the dose was originally given. But sometimes you have to give time for the drug to actually distribute in the bloodstream, but it's usually a pretty quick process, right? It's not like I would give the drug and then take the blood sample, but give it a few minutes or so, right? So let's imagine, and kind of use this pictorial example to give you an illustration of this. So let's imagine I have two different drugs here, right? I have one that's hydrophilic, drug A is hydrophilic, and I have drug B, which is lipophilic. Drug A, being hydrophilic, likes to stay in the blood supply, right? It likes to stay in water. Drug B, being more lipophilic, likes to be out into the tissue, right? The muscles, the fat tissue likes to be out there, okay? So let's assume I have identical twins. And why do I like identical twins? Because they're exactly the same, right? They have the same weight. Let's assume they're exactly identical, okay? Now, again, is it ethical to do studies in twins? The Nazis might tell you yes, but no, that is a bad thing to do. But this is a hypothetical example, right? So we have a set of twins. We're going to give one of them drug A, and we're going to give the other one drug B, and then we'll measure the levels in their blood, and we'll determine what the volume distribution was for those two different drugs there, okay? So we go ahead and give the first person drug A, and we get this concentration of 10 milligrams per liter, right? They're both getting the same dose too, 50 milligrams. And we will calculate it out. We can say, okay, well, the volume distribution is the dose we give them divided by the concentration. They get 5 liters, okay? Versus concentration of drug B was 0.5 milligrams per liter. You're like, well, where did all that drug go? Where did it go? It's not in the blood, so it must be out in the tissue. So when you calculate that out, it ended up being a volume distribution of 100 liters. So again, now do you actually have 100 liters worth of fluid within your body? No, it's ridiculous, right? But it's a theoretical sort of number there to illustrate how far out is that drug really going. And so you can see here that drug B is much more lipophilic. It likes to just go out into the tissue. And clinically, why do I care about if the drug's in the tissue or if it's in the bloodstream? Well, where's the drug working as a question, right? I have an infection, say in the brain, and the drug's not able to get into the brain because it's hydrophilic. It's not going to work very well, right? So sometimes getting to the site of action can be dictated by the lipophilicity and the volume of distribution of some of these drugs here, right? This is why it matters. So just to give you an example, so usually when you get that value of liters, so say 5 liters or 100 liters, whatever the case may be, normally to take that and to apply it to a different patient, I will take their weight out of it essentially, right? So I can take that 100 liters and divide it by a patient's weight, and now I'll get this value in terms of liters per kilogram. This is good because then I can then apply that to any patient I want, right? As long as I know their weight, I can apply it to them. And so just to give you an example here, you see that very frequently if you look this up in, say, Lexicomp or whatever drug reference you use, you'll find that it gets expressed in liters per kilo, and then you'll go through and you find that every drug will have generally a volume distribution associated with it. So something like digoxin, which is used for cardiac arrhythmias, is fairly lipophilic. It's a higher volume distribution, 2 to 5 liters per kilogram, which means if I were to say apply that to a 100 kilogram patient, that volume distribution might be 200 liters. It's pretty big spaces it's partitioning into, right? Versus if I have something, say, like heparin or insulin, that's a relatively low volume of distribution. A lot more of it likes to stay there in the blood supply, right, in the central circulation, okay? In general, I'll tell you that a good rule to remember is if something is greater than 1 liter per kilogram, it is a high volume distribution drug. If it is less than 1, it is a low volume distribution drug, okay? So why might I care about this, right, clinically? So think about being a toxicologist. Say I have that person who would overdose on aspirin, right? Aspirin has a relatively low volume distribution. And say I want to get rid of that drug as fast as I can. Well, one of the things I can do, if say, for instance, the kidneys aren't being very sufficient, is there any way I can like maybe mimic the effects of the kidney? Any kind of machine I can use? I can use dialysis, right? So the question is like, can I pull that drug off using a dialysis, right? An artificial kidney, essentially. Well, if the drug likes to hang out to the tissue and none of it's in the bloodstream, it's not going to work very well, right? I can pull the stuff that's out in the blood, but it's not really going to get to where the drug actually is. Versus aspirin having a low volume of distribution, a lot of it likes to hang out in the blood supply. As I'm filtering off that blood, I can get a lot of that drug out of the system, right? So frequently, whether or not I can use dialysis to get rid of some of these drugs is dictated by the volume of distribution, okay? So just to give you a clinical example where this actually matters, right? So some drugs I can do this on, very few, relatively speaking. A lot of them I cannot do it for. There's some other factors as well, but that's one of the big ones that we consider. So let's give an example here. So let's have someone we are giving the drug to, say, a 70-kilo man, right? So kind of a typical 70-kilo sort of adult. We're going to give 100 milligrams of drug C. And drug C has a volume distribution of 0.6 liters per kilogram. We're giving this IV, so we assume that it's going to be 100% bioavailable. Now, we can estimate what his plasma concentration is based off of this information, okay? So first off, what am I going to do? Well, I'm going to go ahead and figure out what the volume of distribution is for this particular patient, okay? How would I figure that out? Well, I would take my weight, I think 70 kilos, and I would multiply it by 0.6 liters per kilogram. Kilograms will cancel out, and what do I have left over? Liters, right? Which we said volume distribution is measured in liters typically, okay? So I'm going to do 70 times 0.6. It's going to be 42, right? Very good. That will then be equal to, remember our equation here was dose over C0, which C0 is that initial concentration. I'll say, okay, well, my dose is 100 milligrams, and now I need to solve for C0. Now, any of you actually taking calculus? Yeah. You know how much I use calculus in my job? 0. Never, ever, ever. I don't know what the limits of that is, but it's never, right? Although I use algebra all the time, right? So let's go ahead and switch this around so we can actually solve for C0, right? So by flipping that around, we see that C0 equals 100 milligrams divided by the volume of distribution. That means that now I get a concentration of 2.38 milligrams per liter. That's important because I can estimate what that concentration is going to be, and I can estimate is that going to be sufficient to get the clinical effect I'm looking for, or maybe I can determine if it's going to be too much, which might lead to what? Toxicities, right? So again, this is handy because I can, before I even give a dose to a patient, I can figure out is this going to be too much or too little, which is very good to know. Because again, I can try to hopefully prevent adverse effects from happening. I can make sure that the first dose I give is effective versus having to figure it out later on, okay? So we do this quite frequently for certain antibiotics and certain other drugs. We'll do this with some frequency. Okay, so other things that can affect volume of distribution. So some other features here that can be really important in changing this. One of the big ones is going to be plasma protein binding. So if a drug is being bound up by the plasma, or by a protein in the plasma, what's kind of the main one that floats around in the bloodstream? Albumin's one of the big ones, right? There's some other ones as well, but albumin's the main one we talk about. It can actually bind up to a lot of different varieties of drugs. Now, if it binds it up to the drug, where's that drug going to stay, essentially? In the blood, right? So what's that going to do to the volume of distribution? It should decrease it, right? Because more of it stays there in that central circulation, okay? What would happen if I had a patient who was malnourished and they had low amounts of albumin? Because again, if your body's in a kind of a survival state, it may not be producing a lot of proteins because you don't have a lot of protein coming in. So your albumin levels go down. What would that do to the volume of distribution for one of those drugs that is normally highly protein bound? It should increase, right? Because now it's not being bound up by the protein anymore, so it'll just partition out to the tissues. Volume of distribution would go up in those situations. Okay, that makes sense. Okay, what would happen if I had dehydration? So patient's dehydrated, the blood becomes more dilute or concentrated? More concentrated, right? So that means more drugs are going to get concentrated. So that means usually dehydrated patients will have a lower volume of distribution for drugs, right? So this can be important because a lot of times patients come in, they're already dehydrated, right? They were sick before, they had a lot of vomiting, diarrhea, they weren't taking it, have good PO intake, they're dehydrated, right? So sometimes we have to consider that in our drug calculations. Those are things that decrease volume of distribution most commonly. Things that can increase volume of distribution, renal failure. Why do you think renal failure would lead to a higher volume of distribution? Yeah, so I'm not filtering a whole lot, so what happens with all that fluid? You hold on to it, right, and then you get more edematous, right? Now there's more space for those drugs to go. That typically will increase the volume of distribution. Similarly, if I had someone who had congestive heart failure and they had a lot of edematous, they have a lot of edema, or they have ascites because they had liver failure, that also can increase the volume of distribution and give you more space for that drug to go to, right? So again, there's some cases there, and I can ask on a test question, I can say, hey, you got this drug, normally this is the volume of distribution. What would happen to the volume of distribution if the patient developed renal failure? And you would say, oh, it will go up, right? Because again, especially for hydrophilic meds, because it has more water for it to kind of travel into, right? Are you with me so far? Hopefully, it's kind of a tricky subject to get a hold of, but once you kind of think about it a little bit more, it should kind of come into play in your mind a little faster. And so we'll cover some more examples of this later on as well. All right, so moving on. Next up, we have our metabolism. What does this mean? You break a drug down, right? And the ultimate purpose is to get it ready for excretion, right? So this is kind of the intermediary step here. Now, what's kind of the main organ we use to metabolize drugs? The liver, right? The liver is going to be very important for this process, and we're going to get into some depth in terms of what kind of enzymes are responsible for this. The main purpose, though, is to make things more water soluble. Why do we want things more water soluble? Because they'll stay in the blood and get filtered by the kidneys and then eliminated through the urine. That's the ultimate goal for a lot of these things, is to get things more water soluble. There's a lot of different metabolic processes that can actually happen to cause this to occur. Normally, you're going to find that these metabolic pathways will cause deactivation of drugs. What are some cases where we saw activation of drugs? Remember we talked about, it's not an amateur drug, but it's talk about prodrugs at all? I mentioned that? Have I not mentioned that yet? Okay, prodrug. We'll talk about prodrugs in a little bit. But there's been some cases where you can actually activate drugs and actually make them effective by having some metabolism. We'll cover that briefly here in a second. But in general, we're trying to break things down, get them more water soluble, that way they can be eliminated. Okay. So, and in fact, this is the slide where I talk about prodrugs. So, as I mentioned, prodrugs are going to be basically things that are normally, when you take them, say orally, they are physiologically inactive. But by going through the liver, they'll get broken down into a product that is now active. So for an example, here's an antihypertensive. It's in the class called ACE inhibitors. You know what ACE stands for? Angiotensin converting enzyme, right? So you cover the RAS system, so you know that. So it prevents production of angiotensin 2. It helps to lower blood pressure. So enalapril is one that gets converted into something called enalaprilat, and now it is an active drug. Okay. Codeine, anyone ever heard of codeine before? The wimpy sort of opioid analgesic gets converted into morphine. I talked about that example, I'm sure, where it's talking about some people convert a lot of it, some people don't convert so much of it, but this is where you get the actual analgesia from, is the morphine it turns into. Here's another one. Anyone ever heard of Vyvanse before? What is Vyvanse used for? ADHD, right? So again, it's a very popular stimulant. See a lot of kids on this. Well, one of the reasons why it is a prodrug, again, I don't recommend anyone do this, but one of the things that people would do with things like Concertas and Adderalls, normally, do you think those are like immediate release products, or are they extended release? Yeah, you usually see like Adderall XR, or you see like controlled release formulations. Why do we like those for little kids going to school? Take them in the morning, and they last all day. They don't have to like carry meds within the school, and the school nurse doesn't have to hold on to them, so they're kind of good through the day, and then it wears off by the time they go to sleep, presumably. But one of the things you'd find is that people would take these medications and they would crush them up, and then anyone know what they do with them? They would snort them most commonly. Sometimes people would inject them, but they would do it in order to get all the amphetamines right at one time, and it gives you a pretty decent high by all accounts. I don't know personally. I'm just saying this is what people would do. Don't do drugs; they're bad. But one of the things they did is make this product called lisdexamfetamine. This is actually a prodrug. So if someone were to crush this and snort it, it actually really wouldn't do a whole lot for you, because it needs to go to the liver first, which is, again, the first organ you're going to hit after being absorbed from the GI tract, to get activated to turn into dextroamphetamine, which is the active component. So this presumably was being done as an abuse deterrent But you see a lot of kids on it anyway, even if they're not really high risk, because it's just a good drug. It tends to work for a lot of people there. So again, just one example where we can actually use a prodrug for certain purposes other than what you might think about, right? So this is actually an abuse deterrent in these cases. All right, so as I mentioned, metabolism primarily happens in the liver. There's some other places like the GI tract, the kidneys, the skin can have some limited amount of metabolism, but usually the liver is the biggest one there. And you'll find that the enzymes in the liver are going to basically be turning those drugs into metabolites. Now, there's some cases where in most cases, it'll actually deactivate the drug completely. But there are also some cases where it can actually have active metabolites. You actually have products that are actually just as active as the original compound was, right? So that can be sometimes a clinical concern for some people. We'll talk about some examples of that later. As I mentioned, the goal is to convert these over into water-soluble components to get them ready for excretion. Anyway, there's two main phases of metabolism we'll talk about. There's phase 1 and phase 2 reactions, okay? Typically, phase 1 is trying to modify the compound to usually uncover some sort of functional group, or maybe like it'll uncover like a hydroxyl group so it becomes more water soluble, or it's just getting it ready for a phase 2 reaction. Okay, major reactions we're going to run into include things like oxidation, hydrolysis, reductions. Oxidation is going to be one of the main ones we're talking about today because this is going to be the main enzyme system that we're going to be talking about in terms of drug metabolism. So there's a lot of different ones here, esterases and hydrolases, etc. The big one I want you to know, that you need to know, is going to be cytochrome P450. So I've never heard of CYP P450 before. This is going to be a big one. You got to know this stuff. Okay. Now, phase 2 reactions. We'll talk more about CYPs in a minute. Phase 2 reactions are basically going to be generally adding on something to the molecule, right? So they'll conjugate on a methyl group, or they'll sulfate the molecule, or they'll put on a glucuronide group. By doing that, you're again making the product more soluble in water and making it more ready to be eliminated through the kidneys. Okay. Now, one thing that sometimes students get confused on, they're like, okay, we have to go phase 1 and then go phase 2. Not always the case, actually. In some cases, you may find that certain drugs only go through phase 1. Sometimes they only go through phase 2. Sometimes they go through both. It doesn't really matter. All that matters is in terms of that the drug does get metabolized, and you'll see this is a really big spot where we see a lot of drug interactions actually occur by altering the function of these enzymes. So again, just to give you an example of what this looks like, don't get too confused on this topic here, but basically using the CYP enzyme, we're able to get these phase 1 metabolites. They can either be excreted, this pathway, or they can end up going through the phase 2 process and then eventually be excreted, right? Sometimes drugs will go through both. Sometimes we'll just do one then the other. It just depends on the drug itself, okay? A good example of this is acetaminophen. What do we use Tylenol for? Pain relief, fever. Those are the main things, right? Now, acetaminophen undergoes a lot of different pathways here. So, for instance, it can undergo the sulfation pathway. So, by adding on a sulfate group, was that phase 1 or 2? The phase 2, right? Phase 2 is when you're adding something onto it. It can undergo glucuronide conjugation, and you can see here there's relative percentages, right? So again, majority of the time it's going through glucuronide conjugation or sulfation. You're also going to find that it can undergo an oxidation reaction. Oxidation, we said, was a phase 1 or 2. It's a phase 1 reaction, right? It actually forms this reactive intermediate called NAPQI, and then we can actually detoxify that by then going through a phase 2 reaction, you add glutathione onto it, and then it can get eliminated. Okay, so again, this is a case where it has 2 phase 2 reactions, and then it has a phase 1 into a phase 2. It's very drug dependent, right? So you don't have to memorize the slide by any means, but just know that both can happen depending on the drug itself. Now, the reason why I care about this is imagine someone takes a whole bunch of Tylenol all at one time, right? Why would anyone do that? Trying to commit suicide, or in a lot of cases, people are taking this with have opioids in it, right? So you ever heard of Percocet or like a Lortab? It's hydrocodone or oxycodone mixed with Tylenol. So people will accidentally take too much of this stuff for pain relief in some cases. And you find that they will actually exhaust these systems here. They run out of glucuronide and sulfate to add onto those. And that means you're actually going to form way too much of this product here, and that's what causes the liver toxicity. So if you know anything about toxicity of Tylenol, know that the liver takes a big hit with it. Okay, most people probably already knew that, right? What's the max amount of Tylenol you should take in a day? Some people 3,000, but usually 4 grams is really the kind of the max I would ever give someone in a day, right? Depending on their weight and whatnot.
Does age group matter? Because that's what I saw in geriatrics.
Yeah, so for geriatrics, you tend to assume organ function tends to go down a little bit as time goes on, or they're more likely to have liver dysfunction, either cirrhosis or whatever the case may be. So, yeah, in those cases, that would be a little bit more careful with those. But majority of you, 4 grams in a day, probably not going to be a problem, right? However, you take 8 grams or 12 grams in a day, you can overwhelm those processes, and that's where you get the toxicity from. Again, I could go on a 2-hour talk about that, but I don't want to bore you to death today. You can overdose on Tylenol topics, not just the Tylenol itself, right? Anywho, so again, just some examples of the different processes here that can occur. You don't have to memorize all of these. The main one I want you to focus on, though, especially through phase 1, is going to be cytochrome P450. That's the big one we're going to talk about. It's the majority of drug interactions you run into are going to be usually metabolic reactions like this, or interactions like that. Now, I mentioned first pass effect. What is first pass effect? I like the liver tax, right? It's kind of like paying the troll's toll, if you're familiar. Crossing the bridge? No. Basically, whatever drug's coming through the GI tract, some of it may be metabolized by the liver. Some drugs have extensive first pass to where it's not even viable to give the drug orally. Sometimes that's very little to no first pass effect, and almost all of it gets absorbed through the liver without any problems, right? Just very drug dependent. But again, you can find that in some routes of administration, you can bypass the first pass effect and actually get much more bang for your buck out of a given dose. So as an example, if you're looking up, say, drug dosing between, say, oral versus IV dosing, which one of those do you think bypasses the first pass effect? IV, obviously, right? What other routes can you think of that might bypass first pass? Rectal. Anything else? Nasal. Transdermal. They see anything other than oral will bypass it, right? Which is important because you can actually, if you give the same oral dose to someone as or say you just look at a drug dose and say, okay, well, I give this 100 milligrams orally, I'm going to give them 100 milligrams IV, that may be way too much because they were taking into account that first pass effect, right? Now I'll give you another example. This is something I'd really recommend you don't do. Has anyone ever heard of any alternative forms of alcohol that can be administered? Any alternative routes of administration? Some of you are laughing, like you've probably heard of this before, but has anyone ever heard of like an alcohol enema? Anyone know the other term for it? Butt chugging, right? So the emphasis is on the wrong syllable. But I know some of you are mortified and I bless you for leaving such sheltered lives. Some of us have been exposed to some stuff, right? I'm kidding. But basically, that's a big problem. People have died from rectal administration of alcohol because it bypasses that first pass. So you think, oh, I can handle a couple of beers. Well, if you have a big rectum full of it and then you absorb all of that, bypass that liver, you get a lot more alcohol in the system. Because again, the rectum is very highly vascularized, thin membrane, you're going to absorb a ton of it, and thus they get respiratory depression and died from it, right? So this is where you have to be careful with alternative routes of administration, and the dosing may not always be one-to-one. In some cases it is, but sometimes that first pass is really, really important. If you imagine, say, for instance, taking certain illicit substances like amphetamine, some people will take them orally. You do have to worry about the first pass effect, but some people will smoke them or inject them. They will do that to get around that first pass effect, and you get a stronger high out of a given dose, right? So lots of different things you can have to consider about the route of administration. People tried intraocular administration of ethanol, or like a vaportini to actually inhale it. There's lots of different routes, so people try some weird stuff. Anyway, so getting into the P450 system, right? This is, if you take anything away from the metabolism section, please don't let it be rectal administration of alcohol. Let it be CYP P450. I already know I've already lost some of you, but okay. So anyway, this is a really important oxidation system that is used for biosynthesis and catabolism, breaking down these medications into more water-soluble forms, okay? The majority of drug interactions you're going to come across, especially from a metabolism standpoint, are going to be through CYP P450, okay? And we'll talk about specific enzymes here in a second, but these are really important because they determine the level of drugs in the body. And they will determine how long the duration of action for drugs will be. Because if it metabolizes stuff really fast, levels should go down very quickly or slowly. If it's metabolizing a lot of the drug, it should go pretty quickly, right? It should get out of the body very, very quickly. If I have something that is blocking the effects of this enzyme system, it's going to lead levels to be much higher because it's not being metabolized as quickly. So we'll cover more examples of this in a minute, but just know that this is really, really important, and you can get to some really big drug interactions by affecting this system. So there's over 1,000 that we've actually identified individual enzymes, and 50 just in people alone tend to be kind of clinical relevance here. Just know that there's multiple isoenzymes. We'll talk about specific ones in just a minute here, but each one of them tends to be encoded by a specific gene, and we'll classify them based on kind of their homology in terms of genetic sequencing. What that means is that you'll say, for instance, there's the enzyme CYP2D6, right? CYP just refers to the fact that it's a cytochrome P450 enzyme. The 2 is the family, meaning it has some degree of homology there. The D is a subfamily, and then finally the individual enzyme is the 6, okay? That means sometimes you'll find that enzymes will have some cross-reactivity in terms of interactions. So if you take a 2C9 and a 2C19, they tend to be affected by similar drugs because they share a lot of homology there with the enzymes. Okay, so we'll talk about specific ones that are really clinically important in a second. Now again, if you really want to get bogged down to the reactions here, but essentially what's occurring is an oxidation reaction will be happening with this cytochrome P450 enzyme, and you'll eventually get an oxidized form, this product here. And again, notice by oxidizing it, we have the hydroxyl group. Is that more water soluble or less water soluble? It's more, right? Because again, that hydrogen can pop off and it's pretty soluble at that point. So again, this gets it ready to either go to a phase 2 reaction or it can just get kicked out through the kidneys, right? So don't memorize this list. But the point is to show you some of the clinical examples here. Note here when I say substrate, what does that mean? Yeah, it is a substrate where it gets metabolized by that particular enzyme. So for instance, 1A2 metabolizes acetaminophen, caffeine, theophylline, warfarin, right? When I say inducer, what do you think that means? It'll be something that increases the number of that enzyme available, right? It'll upregulate expression of those enzymes. Okay? So if I were to upregulate this enzyme 1A2, what do you think would happen to levels of acetaminophen in the body? Go up or down? Well, I have more enzyme to metabolize the drug. It's going to lead the levels to go down, right? Kind of think about it like Pac-Man. I think about CYP enzymes as Pac-Man. What does Pac-Man do? Womp, 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 womp. So if he's working really fast, because there's a lot of them, you're going to lose a lot of that drug, right? All those pellets are going to get eaten up. If he's being slowed down by, for instance, an inhibitor, those pellets are going to stick around more. They have more drug around. What could that do to your levels? Go up. What can that mean for toxicity potentially? It's going to go up potentially, right? So these are things to consider here as well. So if I say I give a CYP1A2 inhibitor, what happens to the levels of Tylenol? You would say it would go up. So again, keep in mind the relationships here so that way you can understand these interactions. Now, looking at this, which one do you think is clinically would come up most often just based off the numbers? 3A4, absolutely. This is the most important one to note because it is involved in the most drug interactions. Over half the medications you give to people will be metabolized by CYP3A4. If you don't know any other ones, know CYP3A4, okay? Because it is involved in so many different drug interactions here, right? There's a lot of things that will induce it. There's a lot of things that will inhibit it. A lot of things you might not even think about as being a potential factor to consider here, right? So for instance, let me find it. Where's it at? These will focus on medications, but actually, oh, here it is, charcoal broiled foods. So when might you've had charcoal broiled foods recently? 4th of July, right? That can actually lead to induction in some of these enzymes here. You might find drug levels will actually go down, and your drugs will be less effective potentially if it gets affected by that, right? A lot of other drugs will come in and play big roles here. So for instance, anyone ever heard of St. John's wort? What does that do? Anyone know what it's used for? It's used for depression, actually. It's an herbal supplement. It's not regulated by the FDA, but some people will use it for more mild forms of depression, right? Well, it's important because if I have a patient, if you're talking about, hey, what medications do you take? Do you think they would say an herbal product? Not typically, not unless you ask them about it. Especially if you've kind of shown that you're very anti-herbal in the past. Like a lot of providers say, well, that stuff doesn't work. Stuff's terrible. Don't even use that stuff, right? People are less likely to tell you about it. But they could be taking St. John's wort, which could be really problematic because this actually induces CYP2D6. And look at the number of enzymes or number of drugs it could be affecting. It's really, really important. Some of those are psych meds. So you need to ask about these things like herbal supplements because just because they're herbals doesn't mean they don't work. They in fact do. And they can cause a lot of drug interactions too, right? Anyway, so just to give you some examples, remember 3A4 is probably going to be the most common one we're going to mention. Other ones I think are pretty clinically important include CYP2D6, 2C19, and 2C9 are other big ones as well. Okay. And just to give you an example, looking at kind of the breakdown of the number of drugs that get metabolized by these various enzymes here, you notice kind of what gets the lion's share of the pie. I don't know if lions actually eat pie, but CYP3A4 tends to be the most common one here. So over half the drugs you deal with are going to be metabolized through CYP3A4, right? Then we get into some of the phase 2 metabolites or metabolism reactions. You're going to find this tends to be a little bit more evenly split. But 3A4 is just, again, I want to just illustrate why this is so important because so many drug interactions actually occur through this. Now, do you think we could ever use this for our benefit, like a drug interaction? How could we do that? Well, what if I want to like boost levels of another drug on purpose, right? This is really important for HIV treatment, right? So anyone ever heard of highly active antiretroviral therapy or HAART therapy? That's how we treat patients with HIV. Oftentimes what we'll actually do is we'll give those patients a 3 or 4 inhibitor to boost up levels of other drugs that they're taking. So what do you think that does to how often they have to take it? Less commonly, right? If you know anything about HIV medication regimen, especially like in the early 90s, back when it was really kind of early on, like they were taking so many pills a day. It was awful. They would have just a whole table full of pills they were taking all throughout the day, and they had to memorize all this stuff, like when to take what, how many to take. Terrible. Using a boosted form like that, you may only have to give it 1 time a day or twice a day. Which, what does that do for compliance? Goes up, right? So in general, this is going to cause problems, or if you're not, at least if you're not aware of them, in some cases we'll do it on purpose, right? So you ever see certain HIV regimens that include a drug called ritonavir, that's what we're doing there essentially. Okay, so as I mentioned, some drugs can be metabolized through other means in non-liver sort of areas, so the gastric acids can break down quite a bit. So for instance, insulin, you think about someone receiving insulin, how do they normally get it? Injection, right? Why can't they take it orally? Right, it's a protein, right? Insulin's a protein just like any other protein in the body. It gets broken down by the stomach acids, right? And proteases and things like that. So because of that, we can't give any kind of protein-based products orally. It's just kind of a general rule of thumb to remember for that. But yeah, that's one way you can metabolize certain drugs. As I mentioned, enzymes in the intestinal wall, digestive enzymes can all be playing a role there. Also keep in mind things like the gut flora, right? When I say gut flora, what does that mean? Yeah, the bacteria is growing there. They can actually be responsible for some products. So for instance, the colonic bacteria are responsible for producing an absorbable form of vitamin K. So that becomes important for that drug warfarin we talked about. It actually blocks the effect of vitamin K. And so what you can see is that if someone were to have an infection, and you treat it with antibiotics, what does the antibiotics do to the gut flora? It'll wipe them out too, right? Because it doesn't really, it's an equal opportunity sort of offender, so it'll get rid of all those too. That means you would absorb less vitamin K, which makes the warfarin work even better, which means it might work too well, unless your patient may start bleeding, right? So again, this is an important interaction you have to consider in terms of where metabolism is actually occurring and how you're actually modifying that, right? So other things to consider, if you have a patient who has decreased liver function, and it could be for a number of different reasons, you're typically going to find they won't be able to produce as many of the enzymes normally. So if you have a patient with like hepatitis, biliary cirrhosis, any of these things could potentially lead to slower metabolism, which means I have to give more or less drug to the patient. To give less because it's not working as well, right? Because they would have higher levels because their enzymes aren't really functioning as well, right? Make sense? Just things to consider here. Now, there are some cases where renal disease can affect how well we're able to metabolize certain drugs here. So especially if patients have like an acute renal failure or they have like a diabetic nephropathy, things like that can affect how they're going to be absorbing this or how they're actually metabolizing certain drugs. And then also cardiac disease is a problem as well. Especially in congestive heart failure, you have a lot of backup of blood, especially on the venous side of things, and that can slow how much blood is actually getting to the liver. If you're not delivering blood to the liver, that drugs in the blood is not going to get metabolized essentially, right? So in some cases, we actually have to give lower doses. So has anyone ever heard of the drug lidocaine? Anyone know what that's used for? For numbing, right? It's an anesthetic. We can also use it on the heart as well. It actually affects sodium channels in the heart. So we'll give it as a continuous infusion for arrhythmia. Well, for someone who has CHF, because I know I'm not delivering as much lidocaine to the liver because of that backup, that venous backup, I have to give half of the normal dose I would. Otherwise, you're going to find the levels go up too high and they will get toxic. Okay. All right. Some other factors. So looking at things like overall endocrine function, hypothyroidism, what do you think that would do to drug metabolism? Speed it up or slow it down? Right, slow it down. Everything's kind of slow when you're hypothyroid. Hyperthyroid would just do the opposite. You probably end up seeing increased metabolism, right? A lot of genetic factors. We mentioned before that case where some people have a lot of CYP2D6, some people have a little bit of CYP2D6, and that can affect how well or not well you're metabolizing certain drugs like codeine, right? Diet and environmental factors can play a big role here as well. I mentioned grapefruit juice, charcoal, rolled foods can also be affecting this, and then age and gender have minor effect. Typically, the older the patient gets, normally less function. You kind of assume, especially at the kind of extremes of age. But also consider when a baby's first born, do they have a fully functional liver? Actually, no. A lot of enzymes they're not even expressing it until several months after birth. We'll cover that in the pediatric section a little bit later on. And then anything that decreases hepatic blood flow will also slow down metabolism. So any questions on that? So remember, it's CYP3A4. It's a phase 1 reaction. It's going to be responsible for the majority of drug interactions you run into. or at least metabolic reactions you run into, right? Metabolism reactions. Okay. I have a few more minutes. I'm going to continue on, if that's okay with you all. Actually, you don't get a say. I'm going to keep going. The drug elimination. Where do you say most drug gets eliminated from? The kidneys. Kidneys are going to be the biggest one. You'll also find that through the liver, they can be expelled through the biliary tract, where they can be eliminated through the feces. That's a less common one, but that is still one way that you can get rid of some drugs. Again, you may find some drugs will go through both pathways. Some just go through the kidneys. Some just go through the bile. It just really depends, right, on the setting, on the drug itself. Now, as I mentioned, most drugs tend to be freely filtered at the glomerulus. Now, have you covered renal physio yet? Doing it right now? Fantastic, great synergy, right? So the glomerulus normally is, they have those fenestrations that are wide enough that most drugs can pass through no problem, right? You tend to find that a lot of reabsorption of drugs can occur. You may also find that drugs may be expelled or may be secreted into the renal tubule as well. Again, very drug dependent when this occurs. And as I used that aspirin example from before, by changing the pH of the urine, you can actually affect how well drugs may be absorbed or not reabsorbed. And as I mentioned, I can use higher urine pHs to make it so that aspirin is more charged and cannot be reabsorbed, and thus they eliminate it quicker, right? Good for aspirin overdose patients. So again, weaker acids will be excreted faster in alkaline urine and vice versa as well. More basic drugs are going to be excreted faster in more acidic urine. Now, I can give sodium bicarb to alkalize the urine. Is there any case where I try to acidify the urine on purpose? Like give like HCl to a patient? Not typically, right? You never really want to acidify patients. They're pretty good at doing that on their own, depending on the disease process, but alkalize would do it all the time to them, right? And again, I mentioned you have the ion trapping as well. So, for instance, the breast milk is a big one, aqueous humor in the eye, vaginal secretions, and things like that can also be a place where some drugs will be secreted depending on the situation. And again, aspirin, using that as a weak acid, by alkalizing the urine, you can ion trap it in the urine to be expelled through the kidneys. So I'm not going to belabor that point. So clearance overall, though, is kind of taking the aggregate of all the different ways your body's trying to get rid of a drug and kind of adding them all together. So looking at this, you can see the clearance total is basically equal to what goes through the kidneys, what's going through the biliary tract, what's going through kind of other pathways, kind of adding them all up together. Kind of for our purposes, we're just going to assume we're talking mainly about renal elimination as we go forward. But just know there's other ways that these drugs can get out as well. And so again, looking at this, you can find that the clearance, how fast we're getting rid of drugs, is a very important determinant on drug levels. So if I'm clearing a drug really quickly, what does that do to drug levels in the body? They're going to go down, right? Because I'm getting rid of it. I'm expelling it out of the body. If clearance is slower, the drug level should go up, right? Because I'm holding on to more drug in those cases there, okay? This is really important because we need to determine, in a lot of cases, what the renal function of the patient is. So how do I determine renal function? GFR, how do I calculate GFR? Use serum creatinine. There's a couple ways I could do it, right? I can actually measure the creatinine. How would I measure that? You do it in the blood. What's the most accurate way I could do it? I could actually collect urine for 24 hours and then calculate how much creatinine actually got expelled, and I can figure it out that way. That's actually the most accurate way. But is that practical? Here, take this big bucket. I want you to pee in it all day long and then bring it back to me. No one's going to want to do that. But I can use a handy surrogate, right? I can use calculations and use equations in order to help me get an idea of, based off what the serum level of creatinine in the blood is, kind of equate that back to what I think the actual renal function is. What's another good way you can determine how well the kidneys are functioning? What do they normally produce? Urine, and how much urine they're producing can tell me how well they're functioning as well. So urine output is also another very handy marker of how good renal function is, okay? So if someone is expelling no urine for 24 hours, is that a good sign or a bad sign? That's a bad sign, right? So again, using urine output is another very handy thing. Very frequently in children, we use urine output quite frequently to determine kind of what their function is like, right? And so you can either measure that, you can say put like a Foley catheter into the patient and measure it in an actual bag, like over time. How do you think we do it for a baby? So how many diapers? Also, you have to weigh the diapers out, so you know what a dry one weighs, you know what a wet one weighs, what they made, and then you can kind of compare the two and then get how much urine they're actually producing, right? So there's different ways to do that. The serum creatinine, measuring that blood level, is one of the more common things we're going to do to estimate where actual GFR is, right, or where their creatinine clearance is. And so a normal creatinine clearance is usually between 0.6 to 1.2, but that can vary pretty greatly depending on the patient and a lot of other different factors, okay? Now, has anyone ever heard of the Cockcroft-Gault equation? This is one of the more common ways to estimate creatinine clearance for a patient, right? And so, again, I'm not going to have you calculate this on the test specifically, but I want you to know if I modify some of these factors, what is that going to do to my renal function, okay? And again, there's lots of different ones that are out there. So, for instance, the MDRD equation, or this modification of diet and renal disease, is sometimes used for more elderly patients. We have ones that are used for pediatrics, but I think using the Cockcroft-Gault is good for most adult patients and illustrates the points I'm trying to get across here. So, for instance, looking at this, creatinine clearance, which is our surrogate for GFR, right? Looking at this, we see the age is factored into this, okay? So the older the patient is, what do you think it does to our creatinine clearance? So this actually becomes a smaller number. So the older a patient is, the renal function should go down, right? Their kidneys don't magically get better just because they're older, right? So we know that the older the patient is, the worse their kidneys are going to function. Okay, so we factored that in. We factored the weight of the patient in. Why does that matter? Well, where does our creatinine come from? From the muscles, right? So someone who weighs more presumably has more muscle. Is that always the case? No, definitely not. All right, there's some people who go well outside of that. There are ways we can modify that, right? If you ever hear about adjusted body weights, that is something we have to do for more obese patients. But let's just assume for our purposes right now, the patient weighs more, they probably have more muscle mass, okay? And then on the denominator here, we have the 72, which is a constant number, but we have the serum creatinine. So that being in the denominator, if I were to say increase the serum creatinine, what does that do to my function? It decreases, right? There's an inverse relationship here. So if I have a patient who has a serum creatinine of 6, we said normal is 0.6 to 1.2, that shows they have pretty poor renal function because they can't clear it out of the kidneys. It's all being held up in the blood, essentially, right? And then I'll take this and I'll multiply by 0.85 if the subject is female. Now, why would I do that? Typically, pound for pound, females tend to have a little bit more body fat than muscle mass, okay? Now, again, where do they actually come up with it? How do they figure out this is the calculation they want to do? Well, it's based off a study, right? They took a bunch of people, and actually I think this is like from the 50s or something. They took a whole bunch of people, and they were able to actually get the actual true creatinine clearance of these patients, and then try to find an equation that fit that, right? That's how you kind of make a model. And so then we would take that and then apply it to other people. Now, again, you have to consider like, well, 2019 people might be a little different than the 1950s people, but for drug dosing, this is still our standard. This is what we've been using, and it works pretty well for the majority of people, okay? So we know that if I were to increase the serum creatinine, that typically will decrease renal function. If I increase the age of the patient, that will decrease renal function. And if I increase the weight of the patient, that probably should increase renal function, right? So again, you kind of know what the variables are going to do, and they kind of make sense when you kind of think through it logically, right? So anyway, I will cover the rest of this next time. Let me see if there's any questions on the board. Any questions right now? You're with me so far? Maybe not, or I lost you back at the break. That's okay. There's always the video to go back to. Let's see. Okay. Let's see. Doses. Does high volume distribution have to do with when you can detect certain drugs in the hair? It's a good question, right? So why do we try to look for drugs in the hair? Or why would we use the hair to look for a drug? Yeah. So sometimes we'll do it for drug testing, right? And so that's kind of a fraught way to do it. There's kind of some issues with that because imagine even if I say I was in a room with a bunch of people, so I would say I had like 64 people all light and doobies, right? Could there be a chance that some of that would deposit onto my hair? Yeah, so sometimes people who are not even actually being exposed could sometimes still have positive results, which is why we don't like it so much. But yes, presumably if it's a higher volume distribution, it would probably partition into some of that hair that gets formed, and you can actually measure that potentially. Yeah.
Goes through the blood, that's why it's in the hair. So high volume distribution should have a lower?
No, not necessarily. So again, think about it as an equilibrium, right? So again, there's always that equilibrium that's established between, say, the tissues and the blood in terms of where the drug's at. Going from the blood to the hair, though, it has to get within all the keratin and all that kind of stuff. So if it had a higher volume distribution, it'd probably be easier to get into the follicles. Otherwise, it would just stay in the blood and kind of bypass it altogether. If that makes sense. We can actually detect for things like, sometimes heavy metal exposure, so like arsenic or mercury exposures potentially using the hair, but it can be problematic in some cases, especially because, like I said, you could be in a room with someone who is using drugs and still pop positive, even if you didn't use it.